Welcome everyone. This is the NMRA education series, and today's session is about validity, reliability, and bias, which will be led by my fellow co-founder and co-president of NMRA. She's a second year medical student, and yeah, so enjoy listening to Aishwarya and take it away.
Cool. Okay. So, right. Yeah. As Nora said, today I'm going to be talking about validity research and bias. I'm sorry, validity, reliability, and bias in research. Okay, so to start off with, I'll just go through the objectives that we're going to be covering. So, next slide, Nora. Yes. Okay, so we're going to be talking about, firstly, what is validity, the types of validity. Then we'll be going on to what is reliability, the relations of reliability. This will be covered in a more superficial level, the relations of reliability, because of the stats that's going to be covered in the next couple of sessions. But this hopefully will be a good introduction to that. And lastly, we'll be talking about what is bias, different types of bias, and the Bradford-Hill criterion. Okay, so validity. To start off with, what is validity? So validity refers to the integrity or credibility of the research that you're critically appraising. So what it does is it helps to identify whether the results of a particular study on one population or sample size can then be translated across to other contexts or situations. So in simple terms, it essentially tells you how representative the results among the study participants are compared to if that was done, and how that relates to similar individuals outside of that study. So this is particularly important in the medical field because treatment guidelines for treatment are framed around existing research. So you'd obviously want to make sure that whatever it is that you're testing on your sample population within the study can be translated across to the various patients that will be getting the same treatment. And this concept of validity applies to all types of clinical studies, including those that are about associations, interventions, prevalence, and diagnosis. Okay, so next slide, types of validity. So as you can see here, there are definitely quite a few types of validity. There's internal validity, external validity, construct validity, and criterion-related validity. So internal and external validity are the main types of validity. And within external validity, as you can see here, there's also ecological validity, population validity, and historical validity. So out of those, population validity is particularly key. Okay, so next slide. So first I'll be talking about internal validity. So internal validity is a measure of how accurate the experiment itself is. So how free is it from errors, and are the differences in measurement, are they like solely from the independent variable and nothing else, in which case that would be a very high internal validity. And so internal validity is considered, is concerned with the relationship between variables, whereas external validity, which I will come on to in a bit, is more concerned with the universality of the result. So how can what you've learned about within this sample be translated across? So internal validity links quite nicely as well to significance testing in research. So most of you have probably heard about significance testing, but I'll just cover it a bit just so it's a good refresher. Significance testing helps you know if the results that you've obtained are as a consequence of random chance or as an independent variable due to experimental manipulations, i.e. because of the independent variable changing. And it also tells you the likelihood of it being either of those things. So subsequently, you may think, what's the link between that and internal validity? Well, if a study has low internal validity, then that means there's a high chance that the significance test is also low. So the two essentially go hand in hand. So in case anyone doesn't know, significance testing is normally based on two values. So the effect size of the study and also the effect size is p-value. So p-value is probably the one that's talked about a lot more in terms of research. And so when you have a greater effect size, the relationship between the independent variable and the dependent variables is also stronger. And a small p-value means that there's a very small chance that the relationship that is observed is a consequence of just random chance, and instead is more likely as a result of the manipulation of one of those variables. So if, for example, p is 0.05 for a relationship, which is normally the boundary, so then upon assuming that the internal validity is accurate, then there's a 95% chance that that relationship is due to the manipulation of the variables. And there's a 5% probability still that the relationship was caused by random chance. And so the smaller the p-value, then that essentially means it's very, very unlikely that that was due to random chance, if that goes against the null hypothesis. Okay, so next slide. So now I'm going to go on to external validity. So external validity looks at whether the relationship that was observed in the study can be generalized or not. It examines how correct the findings of the research are by looking at how applicable the results from one setting to another is. And so if it is quite generalizable and can be translated across quite easily, then other things to also think about is what settings can it then be applied to, what groups of people, what times can this association and this relationship be extrapolated to. So of course you can think about this in the clinical context and think, this particular study was done, but then how do we now make this a larger study, and then how do we then translate this across and ensure that there are clinical implications of this? Okay, next slide, please. Okay, so this is a nice diagram that I found, which I think quite nicely summarizes internal versus external validity. So hopefully this helps the visual learners amongst you. So internal validity, as I said, focuses on the truth in the study itself. And external validity focuses on the arrow, so the generalizability aspect, and the truth in real life and how that applies. So hopefully that's a nice little summary of that. Next slide, please. Okay, so types of external validity. Three types that I'm going to be covering: ecological validity, population validity, and historical validity. So we'll start off with ecological validity. Next slide, please. Okay, so just start off with the concept of ecology comes from epidemiology and sociology, and epidemiology is very important within research. It's mainly about observing exposure and diseases. So for example, looking at the exposure within a predefined ecology. So now a predefined ecology can be all sorts of things. So for example, it could be Africa, or it could be all patients over 65, and that would be an entire ecology of its own, or it could be Southeast Asians, that would be another ecology. So each of these, it defines them as one, so that's why they're called an ecology. So now in terms of epidemiology, an ecological study looks at outcomes and exposures on a population level where they have a specific thing in common, like geography. In medical research, ecology usually refers to a specific medical environment. So ecological validity specifically examines whether the results of the study are generalizable to real life settings. And when referring to a particular instrument, for example, then its ecological validity can be computed as a correlation. So again, this is kind of leaning into stats, but it kind of looks at the ratings that you obtain with that instrument and see if it's an appropriate measure in everyday life. So ideally, a study should match the same ecology that will be used in practice. I'll give you an example in a moment to help illustrate this point. But essentially, in the study, you want to be replicating the sort of environment in which you want this to be happening in real life as well. So yeah, something else to note is that ecological validity of a study is a judgment. Yeah, so now if I give an example, so let's say there are two studies and they're both trialing the efficiency of a new kind of surgical technique for a procedure. So let's just take an appendectomy, for example, and let's say they're trying a new maneuver or a new technique to perform the procedure. So there are these two identical studies, and the only way in which they differ is that, let's say the first one is using augmented reality. So that's essentially a combination of virtual reality and the actual environment in which you're in. And the second study only uses a surgical dummy. So the first one also uses a surgical dummy, but it also uses the augmented reality, and the second one only uses the surgical dummy. So it's possible that the first study has a higher ecological validity than the surgical dummy alone, because it's more similar to being in theatre, especially with the way that things are moving in the future and augmented reality becoming such a big thing within the surgical field. So that means that there's a greater approximation of the environment. And so that's why a comparison in the study with the augmented reality would have a higher surgical validity. And so just again to kind of clarify a couple of things. So how does ecological validity differ from external validity? So just as a reminder, the external validity is more of the umbrella term, and then ecological validity is a subtype of that. And external validity focuses on the findings of a study and whether they can be generalized to patients with characteristics that may be different from those in the study, or treated in perhaps a different way, or perhaps are followed up for a longer period of time. Whereas ecological validity specifically focuses on whether it can be generalized to naturalistic situations such as clinical practice in everyday life. So it's really quite focusing on the setting. Next slide, please. Okay, so population validity. Now, population validity is how well your sample can be extrapolated to specifically only the population that you're interested in, and that's where the name comes from. Population validity is impacted by the extent to which the study sample mirrors that population and that choice of population. And within population validity, non-probability sampling methods tend to come into play. So if I just explain what non-probability sampling methods are. So non-probability sampling methods are when individuals are chosen, but they're not chosen randomly. So as a result, there's not like an equal likelihood for every single person being chosen. And this is usually done as a result of convenience. Because we have to remember that there are often lots of barriers within research, and so if convenience, if this can help in terms of convenience, it may result in the study actually being conducted as opposed to not being conducted at all. So, however, as you may have guessed, this does have a higher risk of sampling bias. So I will talk more about sampling bias later on, about bias later on, but yeah, this increases the risk of sampling bias. And in this type of sampling, the generalizability, so that extrapolation, is limited to populations that share similar characteristics with the sample, because your sample is already quite niche and they all have a lot of similar characteristics as it is. So it's quite hard to then just apply that to anyone and everyone. So I'll give an example, and hopefully this helps explain things a bit better. So if you had a study that was looking at the motivations of students who wanted to pursue medicine, and then if that sample only included people from urban environments, then that would mean that students from rural environments have been missed out and excluded from the study. So we don't know how the results would pan across due to these differences. And so the differences between urban environments and rural environments include differences in facilities, education, resources, which all may be confounding factors. And there's reason to suspect that the population validity is therefore low. So when you're reading through the literature, this is a really important form of validity to look out for. Next slide, please. Okay, so historical validity. This one is quite straightforward to understand. So this is the extent to which the results of a study can be generalized over time. So let's say you see a paper that's from 60 years ago, and you see an association then, but you then have to think, how applicable is that to now? So that's just something to note. It's more applicable in certain medical fields than others. For example, anatomy doesn't really change that much. And so if there's something that's linked quite closely to that, then it may not change that much. However, if it's something like pharmacology, which changes by the day, then that would perhaps not really be very generalizable and have poor historical validity. Okay, next slide, please. Okay, so I have a question now. So hopefully it'll give you the opportunity to think about the things that I've mentioned so far, because I know that is quite a bit of information I have thrown at you. So let's say you want to find out the relationship between an individual's intelligence and their perception of themselves. Okay, so the target population is all the undergraduate students at your university. Let's just say that's about 50,000 students, for example. Now, obviously, it's not very realistic or cost effective to sample all 50,000 students. So you take a sample of 150 students, and the 150 students you take are all from a maths related background. Most of them are female. Let's say they're around 18 years old and from a high socioeconomic background. Now, they're asked to complete a numerical reasoning test, and you then ask them how well they think they performed, and there's just like a scale, and they say how well they think they performed. And the outcome of that is that the average participant believes that they are smarter than 72% of their colleagues. Okay, so given that information, can you conclude that most people believe themselves to be much better than others at maths? And why or why not? So if you're feeling brave, feel free to unmute yourself and say, if not, feel free to put something in the chat. So I'll just give people a minute if anyone wants to comment anything. If not, I have the answer on the next slide anyway, which I'll talk through.
I was going to suggest that you couldn't come to that conclusion based on the types of things you've used for the criteria of the sample. So only mainly being one gender, the age, and the socioeconomic background could create bias in the kinds of opinions they would have as a group.
Exactly. Sorry, I think my connection may have buffered slightly. Can you still hear me?
Very barely.
Oh, okay. Apologies, 1 minute. Just see if this helps. Can you hear me now?
Slightly better, but you're still muffled. In the meantime, to the person who said, "Oh, I'm sorry, I can't see the chat. Sorry, so I don't know who's been saying." But someone came on the mic and they said that there would be a level of bias from the socioeconomic background and things like that. Why did you say that? What was your reasoning to think that this would cause bias?
So the reasoning I was thinking was because of the kind of question you were asking or what you were trying to investigate, because it's about perception of themselves. You would assume, I mean, maybe that assumption could also be bias that isn't interacting with the bias I'm assuming from the people, but you would assume that due to their background and their subject, they're more likely to be able to evaluate what they would perceive to be smart. And that might influence their attainment and ability to achieve and reinforce that in one way or another.
Okay, so fundamentally, you're making the assumption that because of their background and the nature of the demographics that have filled in your form, that it will not be representative of everyone, correct?
Yes.
Okay, good. That's a fair assumption to make. And how would that impact the validity of your kind of study?
So it would decrease the validity, or it wouldn't be as valid because of that issue with it being representative of such a big population.
Good, good. So exactly, because you've got a group that is relatively small, the sample size on its own is not necessarily a problem, because you can take a small sample of a larger population that can be representative. But because they are from a selective background, you've artificially only picked a certain type of student, and those students, like I said, it's difficult to work out the external validity, because the score of a math student at a numerical reasoning score may not reflect how someone who does a different subject may do, or how someone from a different age may do, because they may have had different learning opportunities in their time at university. So yeah, absolutely.
Yeah, apologies about the technical difficulties. I managed to switch to another device, but absolutely, that was correct. So if we could move on to the next slide, and I'll just talk a little bit more. So yeah, essentially everything you described. The main problem is the fact that it had a low population validity. So yeah, so the sample's not very representative of the whole population, as we've talked about. And I won't repeat everything that was already said, but something to note is that in samples like these, there's something called weird countries. So it's an acronym whereby weird stands for Western, educated, industrialized, rich, and democratic countries. Now, these countries, they're used in about 96% of psychology studies, but also in lots of studies. And even this is the case even though they only represent about 12% of the world's population. And so that can really limit broad population validity. And so that's something to note as well. So when you're going through studies and reading through research papers, do have a look at what countries are being involved, and see whether they're trying to translate that across to countries who are perhaps not in the same category, which, yeah, can make for some very interesting research. But yeah, okay, next slide. Okay, so construct validity. So this isn't necessarily as important as the other ones that we've talked about, but I'll just cover them anyway, seeing as we are talking about validity. So construct validity is the degree to which a research tool measures what it's supposed to, i.e. how well is it measuring what it's supposed to. So it's measuring the validity of the measurement that one is taking, and it's seeing if the evidence supports the measurement that is taken. So if, for example, the measurements let's say there's a study, and the outcome variable of the study that you're measuring is like the improvement of someone's artistic abilities. So then the way in which you're measuring that, is that actually a good way of measuring that person's artistic abilities? Like how are you examining that? Is that a good way of doing it? Or is the method that you've chosen to examine it just actually examining the ability for them to follow instructions as opposed to their artistic abilities? So the two things, although may seem quite similar, are different. And so it's small niches like that, which, you know, won't be explicitly talked about in the literature, but is something that you can keep in mind and perhaps think about. And yeah, you also see, you're also thinking about if what you're measuring is able to help you make an inference. Yeah, next slide, please. Okay, so there's also criterion-related validity. I remember the first time I came across this construct validity. The two are really quite similar. So it's quite hard to differentiate between the two. I'll try my best, but especially just like understand the overall concept behind it, so that you know what you're looking for when you examine the literature. So criterion-related validity is a measure of the extent to which the measurement agrees with the gold standard. So that's the key there. Whereas construct is how good is the measurement at identifying what it is that you want. So let me think of an example. So, okay, let's say if there was a test that could tell you if a criminal would reoffend. Okay, and then 100 people who have previously committed a crime are put through this test, and 90% of the people who were positive of this test, who got a positive result in this test, then reoffended. So that would mean that that is a high criterion validity. That also means that there is a high construct validity. Now, the reason for this is because the test kind of got it right, about 90%, right? So it's showing that the test is good at determining whether or not a criminal will reoffend, but that could only be determined after we knew the outcomes, after we had actually found out if the criminals had reoffended or not. Yeah, so that can be something to think about. So criterion related is best used for obtaining the test result, and then construct is good for variables and measurement. And asking the right questions means a high construct validity. Well, it can mean high construct validity. Yeah, next slide, please. Okay, so now we're going to be moving on to reliability. So what is reliability? So reliability refers to the reproducibility of the measurement when it is repeated at random in the same specimen or subject. So one of the principal characteristics of an outcome measure in a clinical trial is reliability. And yeah, in sort of any measurement in general, it's very important. The reliability of a measurement is also important when it's important to consider when choosing a primary outcome measure for a clinical trial, and also looking at the choice of measures that are used to assess eligibility and exclusion. So eligibility and exclusion are, you'll see that in many studies, understandably. So you want to make sure that you know the people that you're examining are suitable for your study, but at the same time you want to try and eliminate bias as well. And so reliability of measures should be assessed by a quality control program that is based on randomly selected duplicate assessments. It sounds a bit complex, but it's just it's kind of just that the reliability and the outcome and the eligibility measurements allow the author to better describe and for the readers to better understand the sources and imprecision in the study results. and also those who want to follow it, so they can identify these things and then do follow-up studies, because a lot of research you will come to realize is building on what already exists out there. Yeah, in fact, most research, there is at least some element of seeing what is already existing before you can then build on it, even if it's a primary trial. Next slide, please. So relations of reliability. So this is, so I think someone is maybe in the waiting room. I'll just admit them. Okay. Yeah, so yeah, relations of reliability. This is, again, leaning into stats a little bit, but don't worry, this will be covered properly in the upcoming sessions. So the coefficient of reliability is an estimate of the proportion of all variation that is not due to measurement error, and it's readily estimated from replicate measurements. So the reliability of a measurement determines its maximum correlation. So this is also called R2, if you're familiar, and the slope, so also the effect size in regression models. It's also linked to sensitivity and specificity, which you'll hear about when used for classifications or predictions. And it can also indicate the power of a statistical test employing the measurement. So all of these things will decline as the reliability of the measure declines, which is why it's so important. Okay, next slide, please. So bias. I am aware that there was some bias that was covered in last week's session, but bias is such a fundamental part of understanding the research that there's honestly no harm in going over it again. So just start off with quickly, what is bias? Next slide, please. So bias is a systematic error in the design of the study and the methods, and it switches, well, it can skew or even switch the direction and magnitude of an association, which is why we have to be so careful when thinking about what bias may exist in a particular study. And it's important to note that bias does tend to exist in almost all study designs. So it's more just learning to see what types of bias may be present and how that could have changed things. Okay, so types of bias. There are so many types of bias, but I'll cover some of them as many as I can. So there's selection bias, measurement bias, within which there's recall bias, observer bias, and detection bias. And there's also confounding bias. Okay, so selection bias. Selection bias is an error in the way that the sample has been recruited or retained. So, for example, this may be due to if follow-up rates differ between the exposed and unexposed groups, or the sample itself is just not very representative. So again, I'm going to give an example which will hopefully help clarify things a little bit. So let's say that there was a study that assessed hospital patients, and it was looking for a relationship between risk factor burden and their MACE risk. So MACE, M-A-C-E, risk is major adverse cardiac event. And so basically what it was doing is trying to see if how does the number of risk factors and severity of the risk factors determine the likelihood of a person having this major cardiac event, having a major cardiac event. So it found that there was, if there was a high risk factor burden, then there was a reduced MACE risk, which may seem slightly odd. And so one reason as to why this may have been the case is that, firstly, the study only includes a small group of hospital patients, and the patients in the hospital are alive. So MACE can often lead to death. So the study isn't considering high risk factor patients who may have actually already died as a result of the MACE event. And so that would mean that they've already died before even reaching the hospital and are therefore not being considered in the study, which is why this sort of association may have resulted. And this type of bias can only be fully addressed at the stage of study design. So if in the future you do end up designing some kind of study from scratch, then do think about this, but equally, even when reading about these kinds of studies, do keep this in mind. Next slide, please. Okay, so measurement bias. So measurement bias, as the name suggests, means that there's an error in the way that the exposure, outcome, or other factors are measured. So if, for example, the exposed group are checked more regularly for the occurrence of the outcome than the unexposed group, in which case they're much more likely to find the outcome in the exposed group just because they're looking for it in them a lot more. Or perhaps in a case control study, where some people may over-report certain symptoms, or there may be problems with recalling the information. It may not be recalled very accurately, so this is recall bias. So let's say, for example, new mothers with gestational diabetes are being asked about their sugar consumption over the duration of their pregnancy. So because they kind of already knew that they had gestational diabetes, they may then recall more strongly all the sugar they consumed and give a disproportionate recall of, so have a disproportionate recollection of the types of food they actually ate, and instead give a bigger emphasis on the sugary things that they had. And so this bias would result in exaggerated risk estimates. Observer bias is another type of detection bias. It's when a researcher's expectations, opinions, or prejudices influence what they perceive or record in a study. It's not usually very obvious per se. Detection bias refers to systematic differences between groups in how outcomes are determined. So, for example, larger men have bigger prostates, and so that would make diagnosing prostate cancer via biopsy more difficult because it's harder to hit the target. And so therefore, men with larger prostates are less likely to be accurately diagnosed with prostate cancer. So that could be a form of detection bias. And so a real association between obesity and prostate cancer risk may be underestimated as a result of it. And again, this type of bias can only be fully addressed at the stage of study design, but understanding it is still very important. Next slide, please. Okay, so confounding bias. So this is also a very important one. Confounding bias is when the association between the exposure of interest and the outcome is affected by another factor or factors that are linked to both the exposure and the outcome. So let's say there's a cross-sectional study and it finds that there's an increased vertebral fracture risk if a vertebroplasty is done. So just in case anyone doesn't know, vertebroplasty is a procedure that's done to relieve pain from osteoporosis. So yeah, even though that may seem like a causal relationship, what may actually be the culprit here is a confounding factor. So for example, smoking. So smoking decreases bone density and therefore increases the risk of osteoporosis, which therefore means there's an increased likelihood of requiring a vertebroplasty. And also smoking leads to a higher risk of vertebral fracture. So smoking kind of on its own is responsible for increasing the likelihood of A and B, but that does not necessarily mean that A is directly responsible for causing B. So rather than vertebroplasty in this case increasing the vertebral fracture risk, it may be the smoking which is responsible for this. And in terms of how confounding bias can be reduced in analysis, stratification and multivariable analysis can be done. And I'll speak about randomization in a bit, but that's why randomization is so important, because it can really help eliminate a lot of the biases that exist. Next slide, please. Okay, so more types of bias. So there's publication bias. this is, again, something to be really mindful of. So publication bias introduces positive bias for results, as results that are published are more likely to have an association. So for example, maybe journals are picking and selecting studies which show a really strong relationship between A and B, so that it's supposedly a big paper and lots of people would read it. But that doesn't, that may be neglecting some of the other literature that's out there on the same topic, which perhaps doesn't actually show such a strong relationship, or in fact disproves any such association. Yeah, so therefore the strength of the association may be represented inaccurately in the journals. There's also duplicate publication bias. So in this, this introduces bias into meta-analysis, and that puts the results of the same paper more than once, which would skew the results. There's also citation bias. So there's a high chance that a paper that's cited frequently is biased, again, for similar reasons to the publication bias, but also because in a lot of literature, researchers will use other studies to sort of back their findings. And so if a paper is frequently cited, it's probably because it has some kind of positive association. And so lots of people would then be using that in their own studies to back their point. And this is selective reporting. There's also Tower of Babel bias. So this, again, is another bias that's introduced in a meta-analysis. And this is when only English language studies are included in the data being analyzed. So for example, if a paper was in Spanish, then most English readers would not be able to understand the study, and therefore it's disregarded. However, that perhaps if there were many non-English studies which perhaps disproved an association, they wouldn't really be included. Again, kind of skewing the association. And there's outcome reporting bias. So authors may actually miss out some variables which may seem relatively insignificant. So this would also affect the validity of the results too. So I'll give you an example. So some studies are less likely to report adverse events, especially if it's a small number. But perhaps that small number in a bigger population would mean a lot more. Yeah, there's also database bias and location bias. So database bias, for example, PubMed has higher ranking, so it's more likely to have positive results and be published, and more people would be using those papers. And there may also be location bias. So some journals may be embedded better into databases, so tend to come up more easily when you search for things and carry out your searches, and that can be problematic as well. Next slide, please. Okay, so now I'm going to be talking about the Bradford Hill criteria. So you'll learn, you'll learn in the upcoming sessions about what to look out for from a statistical perspective. But the Bradford Hill criteria only applies for observational studies, firstly, just to start off with. It doesn't really apply to RCTs, so randomized controlled trials, because, as I mentioned before, randomization is helpful in sort of eliminating a lot of the biases that exist. So if an association is statistically significant, so normally if P is less than 0.05, and if the confidence interval does not include 1, then it may, that in itself may be oh, okay, this shows an association. But it's important to think more critically rather than just seeing the statistics and thinking, oh, it's an association. So this is a way which can help an individual to judge whether that association is actually causal or not, or if there are confounding factors, like I mentioned with one of the other examples, with smoking being the confounding factor. So it's useful for determining causality. The first 6 criteria are the more important ones and the ones that you should focus on when trying to determine causality. But yeah, I'll cover them anyway. So the first one is strength of association. So if the risk ratio or the odds ratio, the rate ratio is further away from 1, and there's a strong association, then that is more likely to be a causal relationship. If there's consistency in findings, so for example, if you see that association in multiple different types of studies, like cross-sectional, case control, cohort, and you see it in different settings, different populations, and that's also more evidence for causality. If there's a temporal sequence, so this brings in the factor of time. So if A definitely came before B, then B could not have caused A because A came first. Biological gradient. So if biological gradient. So if there is a gradient of increasing or decreasing the risk of the disease outcome as the level of exposure increases or decreases. Think like increase in exposure means increase in the outcome. So that's known as a dose response relationship, and that's also more evidence for causality. Biological plausibility as well. So can you think of some biological reasoning of how that association could actually occur? Is there any biological reasoning behind it? Then the sixth one is experimental evidence, so reversibility. So if there's evidence from controlled experiment that removing or reducing that exposure lowers the risk of the disease outcome, then that's also evidence for causality. So it's quite similar to the dose response one, but in the opposite way. And this is especially if the experiment is a randomized control trial. And then, so those are the main ones. And then the remaining three criteria are specificity, coherence, and analogy. So specificity is if the exposure is associated with one specific disease rather than a whole number of different diseases. But yeah, just even if this this specific criteria is absent, it doesn't mean that there's no causality. Hence why I said it's not as strongly used as the other ones. There's also coherence. So if evidence of an association between the exposure and the outcome is consistent across laboratory and clinical studies and across different manifestations of the disease, this may be evidence for causality as well. And the last one is analogy. So if the relationship has important parallels with already well-established cause-effect relationships, then this may help in the case for causality. And the thing with causality is that this criteria is sort of here for guidance, but ultimately it's sort of down to the individual to try and determine whether or not the relationship is causal or not. So it kind of falls in your hands when you're examining the literature, which is why this could definitely help. So first, work through the stats, look at the confidence interval, look at the p-value, see if there's a statistically significant relationship there. And if there is, then think about what other factors could there be, which perhaps may mean it's not a causal relationship, and use the Bradford-Hill criteria to work through to try and help you think logically about it and see if you can come to a sort of conclusion about whether or not the relationship is causal or not. Next slide, please. Okay, so randomization. Randomization significantly helps when it comes to eliminating bias, particularly for confounding bias. It should ensure that confounders are equally distributed across the control and intervention groups, which tends to be done because of the whole process of randomization. And it can be used to estimate causal effects. Next slide, please.
There isn't one, I don't think. Oh, there it is.
Okay, yeah, so sorry. So I know that was a lot of information thrown at you, but hopefully that sort of made sense. And so internal validity is truth in the study. External validity is the generalizability to real life and the larger population. The various different types of external validity, with population validity being a key one. Reliability is essentially repeatability. and there are lots of links to that, and specificity, sensitivity, etc. Bias exists across almost all forms of research, and there are numerous types of bias, but randomized controlled trials are a better form of research due to their ability to significantly reduce the amount of bias present. So do definitely look out for those when reviewing the literature. And be mindful of publication bias, especially because that's one of the main ways that you will be coming across the papers that you'll be reviewing. And the Bradford-Hill criteria can be helpful in determining whether or not a relationship is causal or not. Yeah, so that's pretty much it from my end. I hope that all made sense. We do have a feedback form. Neeraj, do you want to put it in the chat now, or?
I'm sharing screen. I can't. Wait.
Okay, that's fine. Yeah, I'll just sort something out. But in the meantime, does anyone have any questions? Oh, Neeraj, you can also stop screen sharing, by the way. Okay. If not, I'll just get up the link.
Okay,
to
I'm
share.
back.
One moment. I'm just getting the link ready. It's a bit trickier on my iPad, but okay, I'm just going to pop it in the Zoom chat now. Okay, I've now put that in the chat, so hopefully you should all have access to that. Equally, if anyone does have any questions later on, then feel free to get in touch with us and we can try to help answer your questions. And this will be uploaded onto YouTube as well, the recording soon. So if there's anything that you do want to come back to within this presentation, then you will be able to do so. Have anything to say, Neeraj?
No, I think I just want to kind of add that just as an overall rule, it's quite important to not obviously there are loads of other types of biases that we have not mentioned. There will be a lot of different areas in which you introduce bias and that can affect your results. My main kind of top tip with thinking about this stuff is remember bias always has a direction. So it influences your results in a positive or a negative direction. So always think about like how would the bias or whatever factor you're thinking about, in what way can it lead to a positive or a negative skew in what you're looking at. So for example, most of the biases that you see in publication, especially for like Tower of Babel, database, all these other things, often those biases are very positive biases. So they emphasize the big papers, they emphasize the papers with the strongest positive results. And they often endorse a lot of the status quo. So, if something is currently best practice, it will probably end up being shown to be that way in a lot of studies. And I'm not saying that doesn't exist. I'm just saying that you'll see a skew for papers that will emphasize that. So then if you do a meta-analysis, you're going to find that naturally the results will also be equally positive because that's what you're seeing anyway. So always think about directionality of which way and towards which treatment or which modality of care or more generally, which outcome is your bias leading towards, and it will make sense. You don't need to memorize a bunch of different biases to understand that.
Yeah, and I don't think we've had any questions in the chat as of yet. So I think as long as everyone fills out the feedback form, is there anything else? I don't think so. Okay, yeah, glad you enjoyed the session. And yeah.
So
We hope
thank
to see
you
you
all
next
for
week.
coming. And yeah, next week we will be doing we'll be doing kind of stats and data analysis with Dr. Vicky, who gave you guys a talk 2-3 weeks ago. So yeah, we look forward to having you then, and bye for now.